Good afternoon. I'll be talking about total hip arthroplasty in a patient with ankylosing spondylitis. So as most of us know that ankylosing spondylitis is a chronic inflammatory disease of unknown etiology, affects primarily the sacroiliac joints, the spine, and the hip. It rarely affects the shoulder and the knee. The prevalence is about 0.1 to 1.4%, and male are 3 times involved more than the female. Unlike what you see in the spine, where there is new bone formation, in the hip is actually erosive changes secondary to subchondral bone inflammation. This disease is much more common in Asia and Europe, and much less common in South America and Africa. So the involvement in hip in terms of ankylosing spondylitis, usually it's involved in about 30 to 50% of patients, and when it's involved, 90% of the time it's a bilateral involvement. And usually when patients are young, at the time of the age of the onset of the disease, that's the higher likelihood of hip involvement at that time. Along with a stiff spine and involvement of both hips, the patients usually have a disabling deformity. The recent invention of anti-tumor necrosis factor alpha agents have helped to minimize the severity of the disease and maybe delay the time where total hip arthroplasty as a surgical intervention is required. The goals of total hip arthroplasty in ankylosing spondylitis is to offer our patients relief in terms of their pain, increase their hip range of motion, which is usually stiff or even possibly ankylosed, and together this will enhance their mobility. And we also try to do technically, we eradicate their flexion contracture, and we help them in correcting their posture. And in order to achieve all this, we have to have understanding of some of the preoperative technical as well as anesthetic consideration. So these patients need to be evaluated thoroughly clinically, and in doing that, we got to understand is the patient complaining of pain or stiffness or both. We need to look at their pelvic obliquity and assess that clinically. We also have to assess and quantify the degree of flexion contracture, and is that primary coming from the hip or secondary coming as a compensation from the spine. We also need to assess the degree of spinal involvement, the SI joint involvement, and a lot of time these patients may have symptoms that are equally intense and severe coming from SI joint, and maybe sacroiliac joint injection might help them in partially relieving their symptoms. If need be, I would not hesitate to get a consultation from a spinal surgery colleague. We got to assess the contralateral hip because of 90% bilateral involvement. Although knees are not affected, but it won't be a bad idea to assess the status of the knees and assess the degree of sciatic nerve involvement. This is a diagram showing the degree of posterior tilt or hyperextension of the pelvis. If you could see that the anterior superior iliac spine along with the pubic tubercle are not in the same anterior plane. With the hyperextension, which is secondary to the loss of lumbar lordosis and hyperkyphosis of the spine, this might result in increased abduction angle of your acetabular component and increased anteversion, predisposing to anterior dislocation of your total hip. We need to get a full radiograph of the spine, including the C-spine, a standing lateral view of the pelvis. In addition to the anterior-posterior radiograph of the pelvis, we got to consult our rheumatologist, and if these patients are on anti-tumor necrosis factor alpha agent, that needs to be stopped to prevent any perioperative infection. In terms of templating, we got to assess the degree of pelvic hyperextension, which I showed earlier could be obtained in the lateral view of the pelvis. And this is to prevent placing our acetabular angle in much more abducted position and anteversion to prevent anterior dislocation. From an aesthetic point of view, due to rigidity of the upper C-spine as well as limitation of mouth opening due to temporomandibular joint involvement, a lot of these patients are candidate for fiber optic intubation. Preoperatively, a pulmonary function test is a good idea to get due to the involvement of lung in a restrictive lung disease fashion, and this might predispose them to getting pneumonia or atelectasis postoperatively. On occasions, these patients might be candidate to spend a day or two in a step-down unit to increase their pulmonary toilet and minimize any hypoventilation. ECG and echocardiography may be indicated to assess if there's any conduction abnormality or valvular anomaly. You don't want to get any surprises in the postoperative period. The question is, do we do total hip arthroplasty first, or we correct the spinal deformity first? Well, there are proponents on both sides. Those who believe that total hip arthroplasty should be done first, they believe that if you do that, then the secondary compensatory kyphosis or loss of lumbar lordosis in the spine will disappear. However, you got to understand that if you do the total hip arthroplasty with the coexisting spinal pathology, you will be putting the hip on a higher risk of anterior dislocation. Also, the time of positioning the patient, if the patient does have a very stiff and rigid thoracic and lumbar spine, he may unfortunately be subjected to hyperextension type of fracture during your surgery. So in order to do that and avoid it, it's better to go on with the correction of spinal deformity that will improve the postural changes of the pelvis, and it will help you to position your cup in a much more predictive position to minimize instability. This is a schematic drawing that I borrowed from Dr. Rajesh Malhotra's article, and again, it talks about the way you position your cup if there is a coexisting abductor or adductor contracture of the contralateral limb, and you got to pay attention to that when you're doing your total hip at the time of positioning, because you don't want to be putting the cup in a false position that will give you the impression that this is the appropriate position, but in reality it could be much more horizontal. What are the outcomes in the literature? Well, one of the largest series by Atul Joshi and his group while he was in the UK, 181 hips of patients with ankylosing spondylitis underwent cemented total hip arthroplasty. Average follow-up was about 11 years. The range was from 2 to 27 years. They had 7 superficial infections, 4 dislocations. All of them were anterior. They had 11.6 heterotopic ossification, and 14% of their hips had to be revised. 17 of them were because of mechanical loosening at about 8 years. They reported 96% excellent pain score, but only 65 to 67% good function and range of motion. This is a drawing showing the 71% survivability of their acetabular and femoral component at 27 years. If we look at the literature, the follow-up in the cemented hips are much more longer compared to the follow-ups on the uncemented hip, but at same time milestones, so at 10 years, both of them would have reported about 85 to 90% survivor, but when you go down to 15 or 20 years, the survivorship goes down to about 70 or 75%. The common complications of total hip and ankylosing spondylitis is the predisposition for anterior dislocation, spinal fracture, sciatic nerve palsy, and intraoperative femoral calcar fracture, heterotopic ossification, and aseptic loosening, which is the most common cause of revision in this subgroup of patient population. So in conclusion, I think total hip arthroplasty certainly gives a very good long-term pain relief in large percentage of these patients. The range of hip movement is certainly improved, and this provides our patient a much more improved overall walking ability. The heterotopic ossification re-ankylosing is very low, particularly the clinically significant ones, and because of these patients are predominantly of younger age, component survivorship is an important issue. Thank you very much for your attention.
I would like to invite the next speaker.